Hello and welcome to the Antimicrobials Review 1 lecture. This is the first in two parts of discussing the antimicrobial spectrum in detail, and you're listening to the voice of Lynn Fehrenbacher. So the objectives for our first lecture, you're going to see that we're going to be focusing in this part on the beta-lactam class. So I'd expect that you are able to state the beta-lactam class, given a specific beta-lactam drug, be able to classify where it belongs. When given a specific beta-lactam, I'd want you to be able to explain its spectrum of activity. So what bugs does it cover? And finally, I'd like you to be able to be comfortable with identifying pertinent practical clinical issues associated with these drugs, including certain drug interactions and adverse drug reactions that we'll pull out. This is not an all-encompassing lecture by any means, but we will be discussing some of the more high-level or more common problems that you might see with these agents. So as I alluded to, in the spirit of simplicity, not every organism and every coverage pattern is included, and not every single drug in each class will be listed. I think it's also important for you to recognize your local susceptibility patterns. I realize that there are students in this class from all corners of the country, and so how we may treat something here in the Midwest may differ very widely and greatly from how something is treated on the east or west coast, and that's all based on our antibiograms and our local susceptibility patterns. So please take that into consideration as we're discussing these agents as well. And finally, there's a stoplight coloring coding that you're going to see on the slides that follow. And really what that's meant to do is to provide an at-a-glance look, but patient-specific considerations still should be taken into effect before applying the use of the stoplight color coding. Unfortunately, the scope and time allotted in this course dedicated to infectious diseases doesn't allow us to go back and do a microbiology 101. But this slide is a nice summary slide in terms of organizing the bugs into areas where they're most likely to be seen as causing infection. You can see that some of them are related to the human normal flora. So if any of these pathogens listed here are unfamiliar to you, I'd encourage you to look them up on your own, as we won't have time to discuss them each in detail. That said, same thing for the upcoming slides. If you see any bugs that you're not familiar with, please look them up, or if you're struggling, ask your instructor for more information. So as we think about the beta-lactam class, we classify them or subclassify them into essentially 5 groups. We have the penicillins, which can be combined with a beta-lactamase inhibitor or not. We have the cephalosporins, which now there are a couple of them that do come with beta-lactamase inhibitors as well. The cephamycins, the carbapenems, and then we have one monobactam in the beta-lactam class. So this is really the only structure that I'm going to give you, but it's really to appreciate that the reason we call these beta-lactams is because they all have the presence of this beta-lactam ring. You can see it pointed with the red arrows for you. You can see the cephalosporin on the top looks very similar in terms of the beta-lactam ring structure as the penicillin on the bottom. So that's how this class is effectively getting their name. And they all have a common mechanism of action. So I've simplified it into 4 steps. First of all, the beta-lactam drug binds to a penicillin binding protein on the organism. Then what happens is this drug binding there causes that peptidoglycan chain to no longer be able to cross-link. So the bacteria then can't stabilize or can't synthesize a stable cell wall. And if they can't do that, then essentially the bacteria is lysed and therefore is killed. So these are cell wall type active agents. So the ones that you're probably quite familiar with are the natural penicillins and aminopenicillins. And on this slide, we illustrate for you the two natural penicillins. Penicillin G, which is available in IV formulations, and penicillin V, which is available in oral formulations. When you're looking at this stoplight coloring, I'll give you a high-level overview, but I think if you can focus on the green in most cases, and then on the pertinent reds. So I'll point out a few examples when I think it's important for you to recognize spectrum gaps or failure points. But for the most part, if you can remember the greens, I think that's the good take-home point for these drug classes. So when you think of penicillins, natural penicillins, really the streptococci are the bugs that we're going after with these drugs. Most of them are still highly susceptible to penicillin, and so they still remain a treatment of choice for things like streptococcal pharyngitis, for example. Treponema pallidum causes syphilis, and penicillin remains a treatment of choice for that as well. In terms of a few practical clinical issues, IV formulations are typically dosed every 4 hours in severe infections, and for certain indications like endocarditis, we can actually dose these as continuous infusions. The IM products, I like to call your attention to these more from a medication safety issue, being twofold, that you don't want to give an IM product IV. They do have kind of a milky look to them, so if you haven't seen them already, I think it would cause you to pause a little bit before you would administer it IV because it's not a clear solution. But there's two of them available, and they differ in their therapeutic duration. So there's penicillin G benzathine, or Bicillin LA. That one has a time to peak of about 12 to 24 hours and can be given as a single dose that'll last for 1 to 4 weeks, depending on the dose that you give. Compare that with Bicillin CR, or the penicillin G protein, penicillin procaine, penicillin G benzathine. And that one has a therapeutic duration of only about a day. So you can see we're interchanging these two products, one lasting a week and one only lasting a day, could result in potential clinical failure or toxicity. So the bottom line for these is recognize that there's two different preparations and double check your formulation when dosing or administering this to a patient. The aminopenicillins are widely used as well. Amoxicillin as an oral agent, and ampicillin is available IV or orally, although rarely if ever used orally due to very poor oral absorption. So when you see ampicillin used, it's almost exclusively used as an IV formulation. These again are workhorses against our streptococcal isolates and as well as susceptible enterococcal isolates. And that's probably where I see the most ampicillin being used, is when we have susceptible enterococcal isolates. Ampicillin's also a good treatment for, or empiric treatment for, listeria. You can see that similar to the penicillin, the natural penicillins, poor staphylococcal coverage, and they don't have anaerobic coverage either. So if you do have someone with an abscess, or for example, you may need to then add in other agents to cover anaerobes. With amoxicillin, especially those of you who either have children or have worked in practices that see pediatric patients, there's the phenomenon called the non-allergic amoxicillin rash. And it's illustrated for you here. Typically a maculopapular rash that isn't very itchy or pruritic, and it's most often seen in kiddos. I know my one child had this, and it followed pretty textbook presentation, happened around day 5 or day 6 of the amoxicillin therapy, and with withdrawal of the amoxicillin got better pretty quickly. It can also occur in patients with undiagnosed mononucleosis, and the provider may choose to continue amoxicillin or change therapies, and I think that will be due to their assessment and where you are in the treatment course. But you can safely continue as long as you're pretty sure that this isn't an IgE-mediated reaction. So if there's no hives, if it's that flat maculopapular rash, some providers may be comfortable treating through it. One thing I like to point out is that this reaction as a child does not automatically preclude future penicillin use. So if you have a patient who has this in their history, the provider may choose to re-challenge them or do a skin test to avoid having to skip penicillin use in them for the rest of their life. The next class is the anti-staphylococcal penicillins, and the nice thing about their classification is it tells us where we're gaining spectrum coverage. So the common ones we think of are nafcillin, which is IV, oxacillin, which is IV, and dicloxacillin, which is oral. And as you can see here, now in addition to the streptococci, we have staph, or methicillin susceptible Staph aureus, in terms of having good coverage. One thing to be clear on though is these do not cover methicillin resistant Staph aureus, or MRSA, and they don't have good enterococcal coverage as well. So when we think of these, this is really the pocket for these is methicillin susceptible Staph aureus. So skin soft tissue infections, occasionally when you see endocarditis with MSSA, things of that nature. In terms of notable adverse reactions from the anti-staphylococcal penicillins, there's a few to look out for. They do have typical GI ADRs, so when you think of the nausea, vomiting, diarrhea, you could see that with these. The IV preparations are often associated with phlebitis, so for more prolonged therapy, you may see patients get PICC lines placed. Acute interstitial nephritis is something you should have an appreciation for, especially with nafcillin. What happens is you'll see a renal decline or an increased serum creatinine, and you can see eosinophilia present. And that's essentially what our trigger is when we see that eosinophilia, that rising serum creatinine, and they're on nafcillin. That would cause us to raise an eyebrow for this. Typically, it's reversible when we return the patient or when we stop the offending agent if we identify it in a timely manner. So like the anti-staphylococcal penicillins, we have an anti-pseudomonal penicillin that again sort of tells you where you've gained your coverage. You can see that this is the first time we're talking within the penicillins themselves about expanded gram-negative coverage. So piperacillin, or as we get to an upcoming slide, it's often combined with piperacillin tazobactam or brand name Zosyn. And you see here we gain in the green column good coverage against Pseudomonas aeruginosa, and we still have our strep coverage of the other penicillins, and we go back to having coverage against susceptible enterococci. We lose our staph coverage, so far the only penicillins that have had that good MSSA coverage are our anti-staphylococcal penicillins. And without the beta-lactamase inhibitor, so without the tazobactam, it has poor anaerobic coverage. So why would we combine a beta-lactamase inhibitor with a beta-lactam? Well, one of the mechanisms of drug resistance to beta-lactams comes when the bacteria outsmart the drug and they develop an enzyme that can break down that beta-lactam ring. Once that's done, then it's rendered ineffective and can no longer be used. Certain beta-lactamases can be inhibited by beta-lactamase inhibitor substances. And so you see here ampicillin as our penicillin, and then the sulbactam as the beta-lactamase inhibitor. Amoxicillin as our penicillin, the clavulanate as our beta-lactamase inhibitor, and then piperacillin with tazobactam as our beta-lactamase inhibitors. So what these are doing is basically tying up that beta-lactamase enzyme and preventing it from breaking down the penicillin that it's paired with. So basically, even though these are all beta-lactamase inhibitors, we don't treat their spectrum exactly the same. Ampsulbactam and amoxicillin clavulanate are decently parallel in their susceptibility patterns, with ampsulbactam being IV and amoxicillin clavulanate being oral, or the oral equivalent of the ampsulbactam. And then piperacillin tazobactam is sort of on its own because it has that anti-pseudomonal penicillin parent compound. So you can see that for the most part, for ampsulbactam, amoxiclav, you get good coverage against your streptococci, a little bit of coverage against your MSSA, although definitely not as good as your anti-staphylococcal penicillins, and then susceptible enterococcal isolates. And then when we get down to the Pseudomonas coverage, that's where we really only have pip-tazo coming aboard because obviously the ampicillin and amoxicillin themselves do not have coverage against pseudomonal isolates. You see we gain some enteric gram-negative rods with the addition of the beta-lactamase inhibitor that can help prevent those simple beta-lactamases from breaking down the penicillin as well. And when we add the beta-lactamase inhibitors, that's another area where we wind up picking up coverage for anaerobic agents. So if you think of what do we add with the beta-lactamase inhibitors, anaerobes and some of these enteric gram-negatives are probably the easiest way to remember that. Okay, so we're going to switch then from the penicillins over to the cephalosporins, and I'm going to illustrate the different generations of cephalosporins for you using this background. And for those of you who are closer to a microbiology class, this may look a little more familiar than others, but on your left, as you look at the screen, you can see a gram stain that these are gram-positive cocci clusters. So they're holding on to that stain. They're staining darker purple or dark blue, and you can see kind of the round agents in clusters. So this could potentially be a staph isolate or a gram-positive isolate. And over here on the right, you see more of a red hue, which is indicative of a gram-negative organism, and these are shaped in rods. So this is a gram-negative rod over here. So as we go through by generation, I'm going to illustrate coverage and spectrum of coverage relative to whether something's gram-positive or gram-negative. So we'll illustrate those for you there. And then the first generation cephalosporins, we think of those as a gram-positive workhorse. So as we go up in generation, we start to shift a little bit more to the right or a little more to the gram-negative side with the second generation cephalosporins and have expanded coverage there. Our third generation cephalosporins lose some of that gram-positive activity but gain more gram-negative activity in their spectrum. Our fourth generation cephalosporin, or cefepime, is very broad spectrum. So you can see we gain some of that gram-positive coverage back, and we go even broader in our gram-negative coverage. And then finally, the fifth generation cephalosporin, ceftaroline, kind of goes back to where we all started, but I'll give you the general difference of the first and the fifth generation cephalosporins is that ceftaroline, the fifth generation cephalosporin, has coverage against MRSA. So let's walk through each of these in further detail. So here we go with the first generation cephalosporins. Really the two hallmark ones that you'll see most often is cefazolin, which is an IV formulation, and cephalexin, which is an oral formulation. These are great agents to use for skin infections, or in the case of cefazolin, to prevent surgical site infection. Probably one of the most widely used surgical prophylaxis antibiotics that you'll see out there. So again, these are great for skin flora, so staph and strep, which is why it makes sense that we would use them to treat infections of the skin as well. Don't get me wrong, they can be used elsewhere. They can be used to treat susceptible urinary isolates, etc., but that's just where they tend to fall into play with practice. In terms of the second generation cephalosporins, you remember we're moving slightly to the right here, so we're losing a little bit of gram-positive coverage in favor of gram-negative coverage. And when we look at these, and again, this isn't all-inclusive, but cefuroxime and cefprozil are two oral options. And then cefoxitin and cefotetan are IV cephalosporins in the second generation that are also referred to as the cefamycins. And I think it's nice to kind of pair these in your brain in terms of remembering them, because of the second generation cephalosporins, actually of the cephalosporins, these two have some anaerobic coverage for GI anaerobes. So those two are ones that you may see if you're doing gastrointestinal surgery or people that have intra-abdominal infections. It's nice because you don't necessarily have to put additional anaerobic coverage on those agents. Then we get to our third generation cephalosporins, and you can see them listed for you here. Of them listed, ceftriaxone and cefotaxime are both IV, and then ceftazidime is IV as well. I have these sort of classified by line in that these are quite similar in terms of their spectrum. We gain gram-negative coverage again and lose some of the gram-positive coverage. Ceftazidime also gains pseudomonal coverage. So of the cephalosporins in the third generation, ceftazidime is the only one that would potentially be effective to treat a pseudomonal isolate. Otherwise, you still see strep as a workhorse, enteric gram-negative rods, so the Enterobacteriaceae, things like urinary and GI pathogens. So these oftentimes are used as part of respiratory protocols, so pneumonia protocols often need a beta-lactam, and using ceftriaxone as that makes clinical sense because of the good streptococcal coverage. Okay, so cefepime, you'll remember from the overview slide, has our big, broad spectrum as the fourth generation cephalosporin. Obviously, we don't want to use very broad spectrum agents unless we need to. So cefepime's oftentimes started empirically when we have patients who are at high risk for gram-negative infections, but we don't perhaps have something isolated. So oncology patients, critically ill patients, where they've given us a signal that something's going on and they have an infection and we need broad coverage, but we don't necessarily know what's going on yet. So like I mentioned in that early summary slide, we do have good gram-positive coverage, still no MRSA coverage, however, and then we do have expanded gram-negative coverage as well with the fourth generation. So it was nice when we could just sort of stop there and say, as we advanced in generation with cephalosporins, we gained gram-negative coverage. But with the advent of ceftaroline, or their fifth generation cephalosporin, we circled back and said, well, wait a minute. Now we've got an agent in the cephalosporin class that is an active MRSA agent. So ceftaroline really has been positioned to be used in skin soft tissue infections where MRSA is a player. It can be used in MRSA pulmonary infections, although we'd oftentimes go to another agent before this first. But you can kind of see that sometimes it is nice to have that cephalosporin with additional MRSA coverage on board. But primarily, again, gram-positives, and then our Enterobacteriaceae, or our enteric gram-negatives. So to provide sort of an overview or highlight slide for you to help you as you study, I pulled out what I think are some key points to try to commit to memory about these, realizing that learning spectrum of antimicrobials takes time and practice, flashcards, commitment to memory, things like that, and that really in the purposes of this course, it's going to be difficult for you to feel totally comfortable with it. But I think there are some highlights that are worth trying to focus on here. So within the cephalosporins, if you're looking for one that will cover Pseudomonas, obviously we could have resistant isolates and then they wouldn't cover them, but when you're talking about empiric therapy, ceftazidime and cefepime are the two that you would look to. If you're talking about treating methicillin susceptible Staph aureus or MSSA, think early generation. So first generation cephalosporins will actually have your best coverage within the class for that. If you're thinking of MRSA, that's where we need to go to ceftaroline or our fifth generation cephalosporin because it's the only cephalosporin at all that has any coverage against MRSA. If you're thinking of GI anaerobes that need to be covered, cefamycins, cefoxitin or cefotetin are potential cephalosporins of choice for that indication. And then when we're talking about enterococcal isolates, never use a first through fourth generation cephalosporin to treat enterococcal isolates. Ceftaroline might be an option for you, but it's still not considered first line, and we wouldn't do it without susceptibility information. There are some studies out there looking at, and we've used ceftaroline plus daptomycin together to treat vancomycin resistant enterococcal infections. So there are some data out there with that. But again, when you're looking at committing, what can I remember about the cephalosporins, I would remember never to use the first through fourth generations to treat enterococcal isolates. In terms of notable adverse reactions, very similar to the other beta-lactams in terms of the potential for GI, rash, allergy, etc. Typically, the worse GI effects occur the broader the spectrum. So the more of the GI flora that's wiped out by the cephalosporin, the worse the patient's diarrhea is, for example. With the cephalosporins, we can also see encephalitis. This can happen with higher doses of any of the cephalosporins, but I've particularly seen it with more frequency with cefepime, especially in patients on 2 grams Q8 hours with neutropenic fever dosing and things of that nature. One thing you want to make sure we do with the cephalosporins is ensure that we're looking at them for renal dose adjustment to try to reduce the risk for accumulation and toxicity and developing that encephalitis. Okay, so in terms of a little bit of additional information, the remaining beta-lactams that I'm going to present are typically only used for resistant infections in the acute care setting. I'm just providing you with some information as an FYI only, and I'm not going to test you on the following slides. So there are 2 agents that are cephalosporins now combined with beta-lactamase inhibitors, ceftolozane tazobactam and ceftazidime avibactam. And really where they came to the market indicated were for complicated intra-abdominal infections and urinary tract infections. So thinking of some of the Enterobacteriaceae type infections. One of the things that these brought with them were some expanded coverage against beta-lactamases that would normally wipe out other beta-lactams, such as the extended spectrum beta-lactams, and in terms of ceftazidime avibactam, the carbapenemases as well. So I think that for your purposes, recognizing these agents as ones that would be used to treat either Pseudomonas that we thought was resistant or that had a panel that showed us it was a difficult bug to treat, we may test against these agents, or if we have some of these expanded beta-lactamases that we're detecting in terms of either the susceptibility panel or testing that can be done in lab. The carbapenems are also typically restricted for more severe gram-negative infections. I have them separated into 2 lines for you. Ertapenem is kind of its own kid, and then meropenem, imipenem, and doropenem are decently parallel in their spectrum. So when we think of the carbapenems, we think, like I said, more for robust, ugly gram-negative infections like Pseudomonas, Acinetobacter, or organisms, gram-negative organisms that produce those extended spectrum beta-lactamases that wipe out other drugs in our beta-lactam class. When we talk about Pseudomonas and Acinetobacter, however, ertapenem will not cover those agents. Ertapenem tends to be used more for simple skin soft tissue infections, simple intra-abdominal infections, things where you don't need that real expanded ugly gram-negative coverage. So maybe a little bit better than ampicillin sulbactam in its spectrum, but more similar to ampicillin sulbactam in that it doesn't cover Pseudomonas or some of the other uglier gram-negatives. When we think of meropenem, imipenem, doropenem, we're thinking gram-negative resistant infections almost anywhere. So things like pneumonias, meningitis, skin soft tissue, UTIs, pyelonephritis. So great drugs in that they distribute lots of places, but again, we should only be using them for resistant infections. In terms of practical clinical considerations for the carbapenems, you get the classic seizure tag when you see patients on carbapenems. Again, like the encephalitis, you can see any beta-lactam essentially cause a seizure if you give a high enough dose. Carbapenems really get a bad rap. Some of it's based off of their early study where we probably didn't dose adjust them appropriately. And now that when we use renal dosing protocols, we recognize that the seizure risk is actually quite low if we dose adjust them appropriately. One notable drug interaction that I like to point out, because it is a very acute drug interaction, is one with valproic acid. So VPA can be used to treat seizures or mood disorders, and if you give somebody who's on VPA carbapenem, that can actually decrease their VPA levels by up to 50% within the first 24 hours of duplicate therapy. So it's not a contraindication, but it's something that we would definitely want to communicate with the right team who's managing that valproic acid to make sure we don't have patients have seizure symptoms. And finally, aztreonam. Aztreonam is a monobactam. It's the only monobactam in the beta-lactam class. And the nice thing about aztreonam is the only thing that it covers is gram-negatives. So you essentially lose all gram-positive coverage with aztreonam. So it's an easy one to remember the spectrum. Some Pseudomonas isolates and then most gram-negative rods will be covered by aztreonam. Okay, so starting here, I do want you to know the rest of the slides from here on out, because I think this is an important concept for everyone to understand, and that's of cross-reactivity. So I think the first thing we can do with patients who state they have a penicillin allergy is to get an accurate history and documentation of that allergy. If it's something that they said happened to them in adulthood, but they don't really remember what happened and they weren't admitted to a hospital or an ED, chances are they didn't have anaphylaxis. Most people remember that, so if they can't make a good case for what happened, we would probably re-challenge them in the inpatient setting based off of that type of history. But a true severe penicillin allergy, so an IgE-mediated type, angioedema, big hives, throat swelling, tongue enlargement, there is a cross-reactivity risk with other beta-lactams that we should definitely appreciate. So the cephalosporin cross-reactivity risk is actually quite low, so 0.5 to 4%. So in the inpatient setting, most providers are comfortable giving a cephalosporin to someone with a mild to moderate penicillin allergy. If you get angioedema or anaphylaxis, we're probably still going to look for another agent. For carbapenems, again, it's low, 0 to 10%, depending on what study that you look at. And for those, patients will likely be inpatient if they're receiving them, simply because they're IV only. Aztreonam's structure is different, so the cross-reactivity risk with aztreonam is essentially 0. If you do have a patient who has a documented IgE-mediated reaction specifically to ceftazidime, so for whatever reason they had a reactivity to that drug, there may be an increased risk of cross-reactivity with aztreonam because they share a side chain in their structure. So that would be the only oddball case where aztreonam may be a little bit more risky. So for these patients in the outpatient setting, there may be the role for penicillin skin testing, preferably at a time where there's not an acute need to use penicillin. But once we wipe out the beta-lactams or penicillins by labeling patients penicillin allergic, we not only increase the risk of having to use more costly agents with potentially worse side effects, but we also remove some really great drugs from the arsenal because beta-lactams are fantastic drugs, and when they work really well. So in summary, the beta-lactams are commonly used antibiotics, and they're used irregardless of which practice setting a patient is in. They're readily available both IV and PO, and I think probably almost everyone listening to this today has probably had a beta-lactam antibiotic at some point in their life. So it's important for you to have a foundational knowledge of your antimicrobial spectra for these agents, but really keeping in mind that you do need to design therapy on the level of the patient as well as your local resistance patterns and antibiogram data that you should have access to wherever you practice. And I think that, again, remembering that sometimes not prescribing an antibiotic is a provider's best choice, especially as we're trying to combat antimicrobial resistance and really practice principles of antimicrobial stewardship as we use antibiotics in our arsenal so that we can keep them active and keep them there. So with that, we'll conclude Antibiotics 1, and I look forward to having you join for the second Antibiotics 2 lecture.